everyone. Welcome to Rare Info series conducted by ORDI. Today's topic is Bleeding Beyond the Surface, Hemophilia Awareness. Hemophilia is a rare genetic disorder where blood does not clot properly due to low levels of clotting factor 8, which is known as hemophilia A, or clotting factor 9, which is known as hemophilia B. The key symptoms are excessive or unexplained bruising, uncontrolled bleeding from minor cuts and injuries or following surgeries, sudden severe pain and swelling in joints with or without injury, frequent nosebleeds, etc. It's a genetic condition which is inherited via the X chromosome, where mothers being carriers can pass it on to their sons. Early diagnosis is critical to prevent joint damage and long-term disability. Treatment involves infusing the missing clotting factor. Raising awareness is crucial because for many, the condition goes untreated due to lack of access to basic care. World Hemophilia Day is observed on April 17th annually to raise awareness. It's shocking to know that roughly 70% remain undiagnosed. To throw light on this important topic, today we have Dr. Suresh Hanagavadi, Professor at Department of Pathology, JJM Medical College, Davangere. I'm delighted to welcome Dr. Suresh Hanagavadi, who has done yeoman service in the field of hemophilia. Dr. Suresh
Thank you.
Hanagavadi is himself a person with hemophilia B, has done strong advocacy for hemophilia community for more than 40 years. He has a rich experience in diagnosis, treatment, research, and policy advocacy of hemophilia. He has established centers of excellence for bleeding disorders. He is committed to improving the quality of life for patients through education, awareness, and comprehensive care. Dr. Suresh is from our own Karnataka, and we are extremely proud to invite him to our Rare Info series. He did his MBBS from JJM Davangere and post-graduation from KIMS Hubli. He's a professor at Department of Pathology, JJM Medical College. He's the founder and president of Karnataka Hemophilia Society. He's the advisor to Karnataka State Commissioner, Persons with Disabilities, Government of Karnataka. He is a former president of Hemophilia Federation India. Dr. Suresh established Karnataka Hemophilia Care and Hematology Research Center at Davangere. He is the medical director and he has led two treatment-centered twinning projects of World Federation of Hemophilia with Henry Ford Hospital, Detroit, USA, and with Alder Hey Children's Hospital, Liverpool, UK. He's been awarded with numerous awards and recognitions. He's won the National Award Shresth Divyagnan presented by Honorable President of India Srimati Draupadi Murmu in 2024. Best Service Award on National Doctors Day at IMA Bangalore in 2023. Arka UK Award of Excellence, Karnataka State Rajyotsava Award 3 times, that is in 2006, 2015 and 2021. This list is endless. I'm naming only a few. He's won the National Award of 10 Outstanding Young Indians in 2001. Recently, he's been awarded with Padma Shri by the Government of India in 2026. He's the principal investigator for research projects on hemophilia. He has many publications to his credit. Having seen a life with constant struggle when the resources and medical facilities were minimal, he decided to dedicate his life to help patients suffering from hemophilia by raising awareness and advocating for policy changes. Today, Karnataka Hemophilia Society provides free medical services to hemophilia patients, including medical treatment, blood transfusions, physiotherapy, psychosocial counseling, emergency care, and also free food to admitted patients. His goal is to ensure that every patient, regardless of where they live, has access to the care they need and the opportunity to lead a healthy and fulfilling life. His vision is hemophilia without disability, children free of pain. We are truly delighted and humbled by your presence, sir. Welcome to ORDI. Over to you, sir.
Thank you. Thank you, Aparna, and also Madan Gopal. And ORDI is not new to me. It is very close
Yeah.
to my heart. And I am involved in raising awareness as well as this Race for Seven, so many initiatives of ORDI. Uh, Ours also is a rare disorder. Still more rarer bleeding disorders are there. So we are networking with ORDI in this part of the advocacy. Uh, First, let me thank you for this opportunity. And today we are discussing just about this disorder and to create awareness as well as to bring change in the lives of these patients. And hemophilia, as I told, it is a low volume, high cost disorder. Number may be less, but suffering is so much. So that's why creating an awareness not only among the public and updating the knowledge of hemophilia management among our medical and paramedical professionals also is crucial. To understand what exactly hemophilia, let us understand how normally bleeding stops. Normal hemostasis, we call. So, generally, whenever a person gets an injury, there will be a series of the reactions. That the first and foremost reflex reaction is vasoconstriction, trying to minimize the flow of blood, that part of the injury. But unfortunately, this is a transient process, and that's why it is not going to help in a greater way. But within those few seconds, one more thing will happen. These platelets in our blood flow will be attracted to the injured endothelium, injured blood vessel, and thereby there is a formation of a platelet plug. We call this as a primary hemostatic plug. But as vasoconstriction is a transient process, this platelet plug also has got a limitation. It is very smooth, very friable. Even smaller injuries, it can stop the bleed, but the major blood vessel, even the flow of the blood may detach this platelet plug. So that's why the third mechanism should come into action that we call coagulation or clotting process. And this clotting process, to tell you, there are about 13 clotting proteins in our blood, and each that is a different pathway. I will not go into the details of the this pathway, but there are these 13 clotting proteins act in a cascade, and ultimately culminating in the formation of a strong fibrin. Okay, this strong fibrin will reinforce the already formed platelet plug. That's how the strong platelet plug plus fibrin is the end, and thereby the bleeding stops permanently. But the fourth mechanism also is important. No, though it is not important for today's discussion, we call it as a once the purpose is served, this fibrin, this platelet plug has to be cleared. We call it as a fibrinolytic pathway. So that's why there are vascular function, platelet function, and the clotting function. And ultimately, once the purpose is served, it has to be cleared, otherwise, traffic jam occurs. So, we call it as a fibrinolytic pathway. In hemophilia, the vascular function is normal, platelet function also is absolutely normal. So, that's why when patients with hemophilia will not gush their blood because platelet plug is there that can be produced, and the especially minor injuries may not be a problem, but the major injuries bleed will not stop because this among these 13 clotting proteins, any one clotting protein is missed in the cascade, that cascade will not continue. If it is not continued, there is no fibrin. If there is no fibrin, there is no reinforcement of the platelet plug, and it will fall off, and that's why we call it is blood slowly oozes. So that's why the bleeding in hemophilia is a slow, prolonged, and sustained bleeding because of these components, and especially the failure in the coagulation protein. Okay, so this is normal hemostasis occurs. Then coming to what is hemophilia, as I told you, the any one clotting protein missed in the among these 13 protein, the cascade will not continue. That's why there is no fibrin, and there is no fibrin, there is bleeding continues. So among the 13 clotting protein, most common protein missed in the blood is factor 8, and this we call hemophilia A or classical hemophilia, and this constitutes about 80 to 85%. Whereas hemophilia B, there is one more factor deficiency we call factor 9 deficiency, and which constitute around 15 to 20%, and we call this as a factor hemophilia B or Christmas disease, and this is the name of the patient in whom it was first detected. There is one more clotting protein which causes hemophilia, and very rarely there is one more protein we call factor 11 deficiency, very rare, and this we call hemophilia C. And as I told you, the most common is factor 8 deficiency, followed by factor 9. And global uniform incidence is there, global. So for every 10,000 general population, we see one hemophilic. Or since it occurs predominantly among males, there are one hemophilic child among 5,000 male births. 5,000 male births, male babies, we have one hemophilic. And depending upon this incidence, facts, we have around 4 lakh hemophilia patients all over the world. And among these 4 lakhs, the 25% of the estimated population of the world lives in India. So there are about more than nearly 1 lakh hemophilia patient in our country, but recently we have identified about 27,000 patients with hemophilia and registered with our Hemophilia Federation India, and they receive the treatment and all the other facilities. In Karnataka state, there are about estimated 6,000 hemophilics, but only 2,700 are identified. And hemophilia patients can be categorized broadly into 3 groups. Because normally in any healthy individual, the factor level will be, normal factor level will be varied one, 50 to 200% we say. So any patient who has got almost nil factor, less than 1%, we call severe category. And those patients who have more than 1%, but within 5%, we call moderate. And another category, more than 5%, up to 25-30% of factor level will be there in their blood. And these are the 3 categories we come across in our clinical practice. Why it is essential to categorize like this? So actually, severe patients who doesn't have negligible amount of clotting protein, they are more predisposed to spontaneous bleeding. There may not be a trauma. Night when they sleep, morning when they wake up, they may have bleed in their joint. And also, since it is severe, even repeated bleeding can occur in a weekly once or monthly 2-3 times. More frequent bleeds are expected in severe patients. Whereas moderate patients, they may not have many spontaneous bleed, but definitely they bleed on trauma. Traumatic bleeds are more common. So whereas the mild category, according to me, this is the dangerous category because these patients may not bleed at all. If you take history, they must not have experienced bleeding. But the major trauma or post-surgical bleeds are common in mild category. So mild category patients are most of the time missed in our investigations. That too, in our surgical friends, they depend upon the crude method of BTCT, and unfortunately, mild hemophilics will give normal clotting time, believing that if they take for surgery, then the patient on the OT table, patient continues to bleed. Bleeding doesn't stop. So that's why mild category, either major trauma or surgical bleed or any accidents, then the bleeding doesn't stop. Then coming to hemophilia is a genetic disorder. It has got a genetic basis for the absence of this clotting protein. Let us see how it is. So all of you are aware we have 23 pairs of chromosomes, and one pair we call sex chromosomes, which determines the sex of an individual. Okay, in male we have one X and Y chromosome, whereas females there is no Y and both are X chromosome. And the hemophilia inherent in this is carried by X-linked recessive disorder. So that is the reason hemophilia is predominantly seen among males, because they have only one X chromosome, and that is defective. That's why they bleed. Whereas females, though they have defective gene, defective chromosome, one chromosome, they may not, they don't bleed, because there is one more chromosome which is healthy, which can produce some amount of clotting protein. That's why they don't bleed. But they have this defective gene which they can pass it on to their offsprings. That's why we call them carriers. So males are sufferer, females are carriers. Okay, but anyhow, it is not. Sometimes it doesn't mean that all women born in the family of hemophilia need not be carriers, because the mother, she has got one more X chromosome. If that is inherited to the daughter, she may not be a carrier. Or that is one whichever chromosome, normal chromosome inherited to a boy, he may not have hemophilia. So that's why a woman with carriership may have a boy with hemophilia, and another normal boy also, a daughter with carrier and daughter absolutely normal. So that's why for each pregnancy, this is like a throwing coins. It is their luck whether to get male with hemophilia or normal male, or female with carriership or normal care. Then how to check this? So nowadays the advancement are there. We can detect carriers so that we can offer them prenatal diagnosis and prevent hemophilia in their further generations. And as I told you, hemophilia is a genetic disorder, and there may not be a previous history in their family. So that's why hemophilia is not always familial. So one third of hemophilia families, without having any previous history, that couple may have hemophilic child. So that is because of the sporadic mutations. So that's why hemophilia is a genetic disorder, and 30% without any family history, because of the sporadic mutations, child born with hemophilia may be born. What are the clinical manifestations? Clinical manifestations are as I told you, there were prolonged bleeding on trivial trauma. And as I told you, it is very characteristic because normal platelet plug, that's why they feel it is a slow, prolonged, sustained bleeding. And patient feels bleeding is stopped, but again, after some time, he may re-bleed again. So that's why it is a very characteristic in coagulation disorder. The bleeding is slow, prolonged, sustained. And another very characteristic feature of hemophilia is deep-seated bleed. That means internal bleed it is not just external cuts or external bleed. They may bleed internally also. Most commonly, the weight-bearing joints, knee joints, ankle joints, or any part of the body, they can bleed. And if it is sometimes, rarely, they can bleed even in the vital organs like brain, and it becomes life-threatening bleeds. And sex incidence and inheritance, which I have already mentioned. And yeah, this is how the hemophilic will have a bleed. So this is the most commonest bleed, and since it is genetic, and they are predisposed to repeated bleed in the joint, and that's why the disability is the common companion of hemophilia. And I am showing you a joint bleed in the joint bleed that is knee joint bleed, we call acute hemarthrosis. And they can bleed in any part of the body. This you can joint bleed. This boy has got an the elbow bleed, and here you can see the deep-seated bleed, the abdomen, iliopsoas muscle bleed, bleed which causes a lot of problem. And also, if the bleeds are not treated immediately, there are certain area where we need to immediately treat them. Otherwise, it becomes a permanent disability. For example, as I showed you, psoas muscle bleed can cause deformity, and also if they bleed in the flexor group of the hand muscles, because important nerves and structures pass through, it can cause a permanent disability. If not treated, we call workman's ischemic contracture. They may have foot drop if there is any popliteal area bleed. So these are some of the musculoskeletal complications in hemophilia. As I told you, if they bleed in the vital organs like intracranial bleed, laryngeal bleed, gastrointestinal bleed, and genitourinary bleed, so if it is not treated, it may become life-threatening. As I told you, so the brain bleed is a very serious bleed. We need to immediately replace the missing clotting protein, otherwise they will die. And how to diagnose hemophilia? How to diagnose? One is depending upon the clinical history, family history, and the type of bleeding, especially the deep-seated bleed. With this history, then the pediatrician or a physician, he will advise certain battery of investigations. Why? Because hemophilia, it may be factor 8 deficiency, or if it may be factor 9 deficiency. Which deficiency we need to pinpoint. So this is the standard investigations in hemophilia. So where routine investigation, but here you can see activated partial thromboplastin time. So that means you can say isolated prolongation of APTT, suspect hemophilia, or even Van Willebrand's or other rare bleeding disorder. So classically in hemophilia, isolated prolongation of activated partial thromboplastin is seen. And the next test we do is mixing studies. That is the prolonged APTT. Prolonged APTT, if the normal control plasma is mixed, so that gets corrected. So if it is 80 seconds, if you add normal control plasma and repeat APTT, and it may repeat APTT, it may come around 40 seconds. So that means correction of prolonged APTT by normal control plasma suggests it is clotting factor deficiency. Which factor you need to evaluate further? And another very important here is if it is not corrected. If it is corrected, it is coagulation disorder. Sometimes isolated APTT, if it is not corrected, then you are not dealing with any coagulation disorder. Then you have to suspect other condition we call lupus anticoagulant. That is inhibitors we call. That itself is a separate analysis. And whereas the APTT corrected then confirms it a patient has got coagulation disorder, you have to pinpoint whether it is factor 8 or factor 9. For this, again, we need to do correction studies with appropriate factor deficient plasmas, and also some because they are expensive in resource restricted laboratory, we prepare some special reagents like adsorbed plasma and aged plasma, and try to see whether APTT is corrected or not. If APTT is corrected by adsorbed plasma, then we suspect factor VIII deficiency. And if it is not corrected, then you go with the aged plasma, then you can call it as a factor IX deficiency. But anyhow, the factor assay has to be done to categorize them whether they are mild, moderate, severe. Anyhow, I will not go too much into the details of the lab, and this is just to keep in mind the plasma clotting test, then correction of the isolated prolongation test, and also the factor assay will help us to diagnose specifically. And also genetic diagnosis also is needed, and especially it is caused by mutation. As I told you, the most common is intron 22 inversion in patients with severe hemophilia. So this is the classical diagnostic chart of hemophilia patients. And now, yes, we are discussing about how to diagnose hemophilia. And this year, every year, 17th of April is observed as World Hemophilia Day. And it is a mark of birthday celebration of the founder of our World Federation of Hemophilia, who founded World Federation in 1963 in Montreal. And now we have many national member organization in various countries, and that's how he is the initiator, he is the founder who gave the impetus to the care of hemophilia. As a mark of respect, his birthday we celebrate as World Hemophilia Day. And as I told you, 75% of hemophilia are still undiagnosed, And that's why the theme of this year is diagnosis, first step to care. Because if you don't diagnose, if you don't diagnose, one second. If you don't diagnose, you cannot treat patients. If you have to find if he is a factor VIII deficient, antihemophilic factors with factor VIII concentrate is to be the treatment modality. Whereas if he is a factor IX, then we have to replace factor IX concentrate. So that's why the laboratory diagnosis is crucial in differentiating hemophilia into A, B, or C. Okay, so that's why under the clinical manifestations are alike. That is the challenge. So whether it's A or B, the clinical manifestations are exactly the same. That is hemarthrosis or slow bleed and all those. So that's why it is indistinguishable. Laboratory diagnosis becomes crucial. But unfortunately, being a low volume, high cost disorder, having low level of awareness, it is also the fact that diagnostic laboratories are not available everywhere. So we have so many medical colleges, even this comprehensive hemophilia care modality is not available in many medical colleges. Even that's why we are advocating with the government to set up the basic coagulation lab in a very district hospital, so that the many unidentified or undiagnosed hemophilia patients may be picked up, so that they can be treated with the appropriate factor concentrates. And now let us come to management. Hemophilia being a genetic disorder, it is incurable but temporarily manageable. How do you stop this bleed? So whenever they bleed, we have to replace that missing clotting protein. The missing clotting protein, it all started with earlier, no? It all started with whole blood and even plasma, the wet products, that is whole blood, but whole blood is not a most ideal product because the patient needs only factor 8 or 9, not the whole blood. Then the component separation came in, and FFP, which contains all 13 clotting protein, may be given when you don't know the diagnosis of the patient, or later because it is again a voluminous, and later to process it further and get the precipitate, and we came to know that this precipitate is rich in factor 8. So that's why cryoprecipitate became a modality of treatment to stop the bleeding in patients who are having factor 8 deficiency. Then the pool of plasma is mixed, and appropriate clotting factor can be extracted from human blood plasma. So this plasma derived factor concentrates are now available in the market so that you can treat them specifically. But we were very happy about this life-saving medicine. But unfortunately, then the viral threat came in, and HIV, hepatitis became our patients became innocent victims for this HIV and HPCG. But anyhow, thanks to the growing technology, now we have a product which can be treated with viral inactivation method. Viral inactivation method, the advantage, because HIV virus is a labile virus, heat labile virus. So we started bringing this viral inactivation method like moist heat or dry heat or pasteurization, or various technologies are there so that we can eliminate the viral threat in this during the treatment. And later, the because of this risk, the people switched over to the artificial factor, which can be manufactured from recombinant technology. And the recombinant technology yielded factor concentrate, clotting factor concentrates, and we proved it is effective and no especially viral threat. But anyhow, there was one more challenge. Hemophilia factor 8 or 9, they are all proteins. They have a fixed off-life. Where, for example, factor 8 has got 8 to 10 hours, or for therapeutic purpose, we schedule 12 hourly maintenance. Otherwise, especially the surgery or major bleed needs longer hemostatic coverage, and that's how it is very challenging 12 hourly. So then another technology came. We started using the enhancing these factor concentrates, enhancing the half-life of these factors, the 8 to 10 hours, now it has become 36 hours, so that we can achieve longer hemostatic coverage and treatment. And especially these are all the universally there are two modes of treatment. Whenever they bleed, you have to replace the factor, or in Western countries, with whether they bleed or not, weekly 3 injections of factor 8 or 2 injections of factor 9, we call prophylaxis. So this was followed in the Western country. They treat they in our country we were treating bleeds, whereas in Western country they don't allow their children to bleed. But anyhow, the extended off-life factors, it became easy for us, and but ultimately the prophylaxis, as per our World Federation of Hemophilia, is a gold standard treatment because it prevents disability and it improves the quality of life. But anyhow, there were challenges like adherence, IV, and all those. Even in spite of these extended off-life factors, it was difficult for us to even manage. Even breakthrough bleeds are known to occur even in prophylaxis. So then the drug nowadays it has come, we call non-factor therapy. So all these years we have used factor therapy, factor replacement, whereas now the technology has come up to rebalance the normal hemostasis. Normal hemostasis is nothing but balance between coagulation protein on one pawn and fibrinolytic proteins on other pawn. And if patient is deficient of factor 8, factor 8, don't bother about that pawn. You look at other pawn, you produce monoclonal antibody and remove one fibrinolytic protein so that hemostasis becomes balanced one. And balanced hemostasis will cause zero bleed. And zero bleed means no blood in the joint. And no blood in the joint means no disability. So now we have this emicizumab, a molecule for factor 8, and even fitusiran for factor 9. I will not go much into the details. At least these non-factor therapy has revolutionized the treatment of hemophilia in achieving zero bleed and preventing disability and also improving the quality of life. And especially our patients are our children. It is very great challenge for them to get education because they cannot go to schools regularly because of the repeated bleed. So that's why this emicizumab has proved very effective therapy. And now this another important advantage of this drug is it can be given subcutaneous, whereas factor concentrates you need to give IV, intravenous, and especially neonates or small children, it is very difficult for us to get the vein. And also the subcutaneous mode of administration of this drug, like in diabetics taking insulin, the modality has come in the hemophilia world, and we can give these emicizumab and prevent almost. We call the and another very important advantage is half-life. I was telling you 8 to 10 hours, 20 to 24 hours in factor 9, enhancing half-life. But now this emicizumab has got 1 month of half-life. So that's why longer half-life and the subcutaneous mode of administration has given lot of advantage to see that the drug, these patients, you can prevent bleeds. And the last, of course, we are waiting for this. This is a curative treatment, and placing factor 8 or 9 transgene within the AAV, that is adenoviruses vector, and give this vector molecules into the patient through IV, and vectors infect the liver cells, that is hepatocytes, and these hepatocytes would then produce factor protein, and that's how they are totally cured from hemophilia. And in our country, or in CMC Vellore, there are 3 clinical trials which have shown promising results and hope of getting gene therapy so that we can get rid of hemophilia. And because of the low volume, high cost disorder, and because the lack of awareness, because lack of diagnostic facilities, most of the patients, they become disabled. That is deforming hemoarthropathy, and even this bloodborne infection, to some extent it is under control because of the viral inactivation method. And so that the joint bleed and the what you call progressive disability is another. So that's why in India we have this kind of common scenes by the time the children gets into their adolescent age group. And so one more complication, over a period of time after receiving these factor concentrate, our body thinks that it is a foreign material, and it produces antibodies against this life-saving medicine, so that such a expensive life-saving medicine becomes totally ineffective, posing a challenge in managing for the controlling bleeding further. So that's why we have to go for factor 8 becomes totally ineffective, where at that time we have to go for bypassing agents, that is activated prothrombin complex and the activated factor 7. is but they are all very, very expensive. So, but anyhow, through immune tolerance, we can bring down these antibodies. But again, after getting drug like emicizumab and all those, so immune tolerance therapy is very expensive, and sometimes it may be successful or may not be successful. So that's why the new modality of treatment, most of the inhibitor patients is advised. And prevention, as I told you, hemophilia, males are affected and females are carriers, but all females need not be carrier. So that's why we have to take up for carrier detection test. And if she is found to have carriership, then subjected for prenatal diagnosis, and we can do amniocentesis or chorioneculus biopsy, take the sample, test the fetus for hemophilia, and legally these women are given the medical termination of pregnancy. So that's why MTP is legal if the fetus is found to have hemophilia. So, yes, again, we lack clotting proteins only, nothing else. So, that's why we need to motivate the patients, we need to educate them, and how to live with it, we have to teach them. So, these are some physiotherapy, general principles of health, and one more very important, they must avoid the aspirin drug which interferes with the platelet function, and very common analgesic we advise is simple paracetamol. And we conduct camps and all those to teach them how to live with hemophilia and lead almost a normal life. And from the history pages, I would like to share something. And hemophilia is not very new disease. And in the Bible, there is a mention of a woman's third son was exempted from the ritual circumcision because she lost two children to the ritual circumcision. And also it is known as royal family disease because it plagued a royal family. Queen Victoria was a grand carrier. Her daughters were married to different kingdom in the European kingdom, and that's how hemophilia is in the royal kingdom, and popularly known as royal family disease. And yes, to conclude, hemophilia therapy is rapidly evolving. As I told you, it started with the blood, plasma, cryo, and anti-hemophilic factors, recombinant factors, and enhanced half-life factors. And now we are talking about non-factor therapy, that is rebalancing factors, so that it has revolutionized the treatment of hemophilia. Factor replacement is still the mainstay in some of the countries, and non-factor products playing an ever-growing role, and especially in improving the quality of life in these children getting proper education. And gene therapy is right around the corner. We are hoping of this gene therapy. Just a few, let me share that how we started Karnataka Hemophilia Society. Our vision is hemophilia without disability, children free of pain. In India, we have 100 plus chapters all over the country affiliated to Hemophilia Federation India, which is a satellite body of World Federation of Hemophilia. And yes, as far as our local chapter is concerned, and we are very happy and proud to share with you Dr. S.P. Balasubramaniam is involved as a patron in chief and helped us till his last year of life in raising funds by giving mega events or concerts to raise funds. And the other woman, the Kiruwadi Girjamma, she donated a piece of land. That's how we could construct an exclusive treatment center, and not only for hemophilia, all rare inherited bleeding disorder with all the facilities under one roof. Even Hamsalekha also joined, other celebrities also joined hands with us and supported. In fact, Hamsalekha wrote a song on mothers, how they suffer badly in the family. And recently, with our continued consistent advocacy with the government, non-factor therapy is made available to most of the children. Now it is distributed all over the district hospitals, all over the Karnataka, and all district hospitals have started emicizumab, especially to children and patients with inhibitors, and so that we hopeful of hemophilia without disability among these children. I must thank our government of Karnataka, our health minister, and our deputy chief minister who launched this project. In the month of February 25th in Bangalore. And this is our center. And if anybody comes or anybody visits Davangere, you can visit our center. And we are able to provide all the facilities under one roof: diagnosis, treatment, and rehabilitation under one roof, and even 3 meals along with the patient's mother or father. We provide them totally free of cost. It is not only this, even our blood bank with FFP, cryo, not only hemophilia, so we give totally free of cost to all inherited bleeding disorders for their treatment. I am thankful to, thank you very much uh, for this opportunity on the occasion of World Hemophilia Day, and let us all work together. Still gaps are there, and we need to be together and advocate with the government to fill these gaps. Thank you very much, madam. If there
Thank you
are
very
any
much,
questions,
sir. That was a wonderful lecture on hemophilia, and ORDI truly appreciates, and ORDI is thankful to your knowledge gaining, no, knowledge parting gesture, sir. Thank you so much, sir.
thank you, madam. If
Yeah,
there are any questions, I am happy to
yeah, I
answer.
think Madan sir has put a question. Please
Sir,
throw
if you
some
can,
light. Madan,
Yes, sir.
you want to ask? You please ask.
yeah, just because of your advocacy efforts and your continuous, programs on hemophilia, the government of Karnataka launched Kusuma Sanjeevani.
Yes,
So
sir.
if you can just help us with more detail, so that the patients who are suffering from the blood disorders, especially hemophilia, how can they approach this? Because I have read this on newspapers when you launched this on the 25th of February this year. So we wanted to know more about this, the implementation and other things. Just some light on Kusuma Sanjeevani program, sir.
Yeah. Actually, Kusuma Sanjivini, because hemophilia is known as Kusuma Roga in Kannada. Okay, that's why when we told this fact, and this name was coined for this project. Kusuma Sanjivini. Sanjivini means in Vindhya Parvata story.
Yes, sir. Yes.
And this is a particular factory 8 or 9. And this is being provided free of cost to all our hemophilia patients all over Karnataka. And I'm really proud and proud to share with you in 2005, we became success in getting the budget allocation for these medicines. But over a period of time, especially after the involvement of the National Health Mission, so now there is so much of improvement. Earlier, it was only selected district hospital. Now, all the district hospitals are providing these medicines at free of cost. Okay, and now non-factor therapy is added. So total 42 crores of rupees is budgeted under health, and the different factors, that is extended half-life factor. It includes extended half-life factor, and non-factor therapy. We were very particular about providing this medicine to children, because in our case already we are disabled. There is no much, we may not be beneficiary for this non-factor therapy. But anyhow, we have categorized the patients. That is number one. Our priority is children, because we want to prevent disability. And the next priority is the patients who have developed antibodies to factor 8. We call inhibitors. And the management becomes almost 5-6 times more costlier. That is, even we understand government budgetary implication. So instead of these bypassing agents, it is ideal to put them
Correct.
on this non-factor therapy. It is, it will not cost much. That is second category. And there are third category of patients who suffer a life-threatening bleed. For example, the brain bleed. And once they suffer brain bleed, there is all possibility they may re-bleed again. Maybe within month or maybe within 3 months, they are going to bleed again. Again, to prevent this morbidity, we prefer them to be put on non-factor therapy, so that there is no bleed at all, and they can live without any fear of re-bleed. That is third category. And as I told you, the neonates, sisters or even doctors, we struggle a lot to find the vein. And a way that is vein accessibility is very difficult. So for them, that's, as I told you, non-factor therapy is ideal. So these are certain criteria. We have made standard operating procedure. Our technical committee of state blood cell has made the SOP, and it is distributed to all over district hospitals. And now even I am going. Yesterday I was in Belgaum, so because just to train them or orient them, and we are going because government's ambitious project incurring crores of rupees should be utilized promptly. So we are also responsible. So that's why we orient, we train, and we even orient our families also. Okay. Okay. So this is about Kusma Sanjivini. And one more project I would like to share here is, so when I was presenting our Hemophilia Society annual activity, we run one more project we call Mobile Service Unit. And Mobile Service Unit, why we conceptualize? Because I have seen many of my blood brothers while reaching Davangere, they have succumbed to these bleeding episodes like brain or abdomen, and they died in KSRTC buses. They died on the road. So that's why it was very painful for us. Then after setting up the society, basic thing, then we looked at this part, and we advocated with the Rotary Foundation, and we were successful in getting a ambulance free of cost to our center. And we have made a project proposal, 125-kilometer radius. Anyhow, we have a database of our patients, and all these patients were trained in sensing the earliest sign of life-threatening bleed. For example, brain bleed, the signs will be headache and projectile vomiting. And if they have this, if they develop this, they need not come to Davangere by catching vehicle or any mode of travel. What they are supposed to do is take their mobile and call to our mobile service unit. Our team will go to his house or village, first infuse this factor and bring him in the same ambulance to our center for further management. Like this way, we could save many life-threatening bleed. And when we explained this to the government and our health minister and principal health secretary, they were so much impressed. And I told, we are submitting a proposal shortly, sir, after gaining some experience. Then they told, why to wait till you submit? we can integrate this into 108. And now that's what our Deputy Chief Minister and Health Minister launched along with Kusuma Sanjeevani this emergency bleed management by 108. This is another, these two projects were really this thing, very proud achievements of our advocacy.
Definitely, sir. Life saving and these kind of works, and truly deserve that. You receive a Padma Shri for all the works you have done.
Thank you.
Thanks a
Thank you.
lot. Thanks a lot, sir.
Thank you. Yeah. Thank you,
So,
madam.
how can schools and workplaces better support these patients with hemophilia?
Yes, sir. Very right question you asked, madam, because lot of issues are there in the school. And one thing I told, our children cannot go to school. Now they can go with the the treatment modalities are available now. But teachers doesn't know. And now we are successful in bringing hemophilia, thalassemia and sickle cell under Disability Act. Okay, and that's why we are taking up a lot of programs to train teachers how to take care of these patients when they are, if there are any hemophilia children in their school. And that we are doing, but again, as it is not that easy. But anyhow, whoever teacher we have trained, they are taking care of these children very well. And especially there are certain things we need to advise, that is the prevention of the certain games they are not supposed to play, like body the
Kabaddi
cricket,
and all those things.
yeah, kabaddi and all those. We have to educate them. And now we are helping, we are taking this project, going to different schools and conducting orientation program for teachers. And another thing is, even nowadays from residential school, no, there will be staff nurses also. And now in and around Davangere, we have trained staff nurses. And now if any hemophilic are there, they know how to give factor immediately.
Okay.
So these are some, again, it is a learning process, and we are trying our level best to bring change.
Okay, okay. So, what's the financial burden on the family? Like every time they have to give the factor 8, like you very rightly mentioned that it is given free of cost in many hospitals. Like, but for a new person, for a new patient, or a new family which has come to know that the child has hemophilia, like what's the financial burden on that family, and will
Yes.
insurance cover that? What about
Yeah,
insurance, sir?
yeah, that is another challenge. Actually, the
Very
financial
important
burden,
question.
with our advocacy, now government has taken care of the major burden, that is factor concentrates or any replacement therapy is available free of cost. But anyhow, there are certain issues like the insurance still is not given to hemophilia patients, but education support, and we within our limitation we have made certain projects, like we give scholarship to the children with hemophilia and encourage them to study well, and see, because the education is very very crucial. So in that way, and also certain projects we have, small projects, we some philanthropists, no, they support total education support to our children or youths. And also one more thing I would like to highlight here is, so it is challenging to get education, but unfortunately, though hemophilia, thalassemia, sickle cell disorder are included under Disability Act, but just they are omitted from benchmark disability, they are denied job reservation. And this is one area we are continuously advocating for inclusion of hemophilia, thalassemia, sickle cell under job reservations.
Okay. So, lastly, sir, one question: what is the status of the clinical trial for gene therapy in hemophilia in CMC Vellore? You said a lot of work is being done. if we have a new registration in ORDI, like, can I tell them, can I give them can I offer gene therapy for them? Like, what is the status of that in CMC?
No, actually, very still it is premature to commit, madam. But I am sure that 3 clinical trials studies are successful, and recently, even in CMC Vellore, they have successfully conducted this clinical trial, but only the cost is exorbitant. That part we don't know exactly, to be very frank with you. I think maybe within a year we will come to know the exact scenario, so that gene therapy is available to everyone, and
Are they
everyone it is.
enrolling patients? Are they
Yeah,
enrolling
yeah.
patients?
They are very not many, madam. Just around few patients are enrolled, and but as I told you, because of the cost and all those, it is not yet taken up properly. I think coming days we may have good hope.
Thank you very much, sir. That was
Thank you.
exhaustive and a beautiful presentation of
In fact, actually,
hemophilia to all of
in
us.
fact, actually, because I was a little this thing, because whether to address the common man, the even medical people, medical students. So I have covered, I have included everything and given in a very
Yes,
nutshell.
yes, yes. Thank you very much, sir. Thank you.
Thank you, thank you, thank
Thank
you
you.
very much.